Okay, so one of the things that they look at for testing is first with an impaired fasting glucose test. And that is what we're going to see here with the prediabetes. So they look for the impaired fasting blood glucose to be 100 to 125. So they do a fasting blood glucose where you fast for overnight for about 12 hours. You go in, you get your blood taken, and they look to see if it's somewhere between 100 and 125. They could also do a glucose tolerance test, which is an oral glucose tolerance. Basically, what you do is you get your blood taken, you take, you drink then 75 grams of glucose, and then 2 hours later you take, 1 to 2 hours later, depending on the test, they will then take your glucose levels again. And if it's between 140 and 199, it would be considered impaired glucose tolerance test, which would be pre-diabetic, or an hemoglobin A1C of 5.7 to 6.4%. If they have an absence of overweight and risk factors, then the recommendation is all people over 45. If the results are normal, they ask that they repeat it every 3 years, and the risk status may require more frequent testing. So that's the recommendation by the American Diabetes Association. However, most PCPs will test your blood glucose even at the age of 20. It just might be 5 years in between tests, somewhere between 3 and 5. So they might not be doing it every year, but they will be testing it more frequently. So don't feel like you have to wait till 45, or patients have to wait till 45. It can be done and it will be covered by most insurances, but you just might not have it as frequently at a younger age. Prediabetes, there's instruction and encouragement to really decrease the risk of developing type 2 diabetes, and under the Affordable Care Act, there's now insurance covered access to proven lifestyle intervention programs that can help prevent or delay development. So we'll talk about that briefly. I'm not going to get into too much detail, but I'm going to tell you about some of those programs that are available for individuals to help assist with reducing or delaying the development of these diseases. So this is the criteria for the actual diagnosis of diabetes, and this is pretty straightforward, so I'm going to leave this here for you, but you do need to know these numbers in order for you to understand where diabetes is actually diagnosed. Hemoglobin A1C is one of the big ones that we use for confirmation, and so typically we start with a fasting blood glucose. If that is over 126, they tend to move oftentimes to a 2-hour plasma glucose, or through an oral glucose tolerance test. If they fail that, then they may go on to test the hemoglobin A1C as well to be able to confirm that diagnosis. And when diabetes is not controlled, the way the hemoglobin A1C works is glucose will build up in the blood and will actually combine with hemoglobin, and hemoglobin will become what's called glycinated. This test measures the percent of hemoglobin that has glucose attached to it. A higher percentage means poor control and more risk of diabetes complications. If glucose levels have been high over recent weeks, your hemoglobin A1C test will be higher. And the amount of hemoglobin A1C will reflect the last several weeks of blood sugar levels. So usually, when we look at that, it can kind of tell us what has been happening in the past 6 to 12 week period, or 2 to 3 month period. So it's a test that really says, okay, this is not just a fluke day. This is something that's been occurring on a regular basis. And that is something that they take a look at. So what is the treatment? In general, evidence-based guidelines really wants to have appropriate care. Good diabetic control is important for the ability to handle to control diabetes. So they recommend regular HbA1c testing, dilated eye exam, foot exam, blood pressure monitoring, lipid panel, having renal functional tests. If they're smoking, really get counseling to reduce that, making sure they're getting flu or pneumonia and immunizations, and really attending diabetes education, which really talks about purpose and importance of medical tests, gives them feedback about the results, educates them on the results, and also talks to them about ways in which they can help to better control their diabetes through diet, exercise, and weight control. The pneumonia bacteria is really important in diabetes control, having an immunization for it, because again, their immune system is going to be compromised. And this particular bacteria causes many types of diseases, including meningitis and ear infections. And so by having this immunization, it helps to control some of those factors. So what are some of the basic guidelines then for diabetes care? There's going to be physical and emotional support. Typically when they go for their PCP visit, it would be blood pressure, weight, and BMI every visit. Their target goals are here, and then also to have a foot exam every diabetes care visit. They recommend for two different types, having a dilated eye exam. So shortly after diagnosis and every year for type 2, for type 1, 5 years post-diagnosis, and then every year after that. Really making sure they have their oral exams, dental exams as well, because we talked about how that can impact immune response and disease states, particularly cardiovascular disease as well. Depression, to really make sure that they're feeling that they're able to control the disease. Having a hemoglobin A1C tested quarterly if they're not meeting goals or their treatment changes, and 1 to 2 times per year if it's stable, just to make sure that we're really controlling that. Again, looking through these blood lipids every year, taking a look at that, and then also self-management. So we really recommend them self-glucose monitoring, prevention of complications through several self-care behaviors. And so they have identified 7 self-care behaviors: healthy eating, being active, monitoring, taking medications, working to problem solve or cope with challenges, and reduce other risks such as smoking or alcohol consumption. And then screen for problems such as, keeping a lookout for their eye health, their foot health, any sort of numbness, those kind of things. Physical activity should be looked at initially and ongoing to really make sure they work on that. Same with weight management, and of course medical nutrition therapy as well. So there's lots of different interventions, and again, I'm not going through this in great detail right here because you can read it, because I am going to spend some time talking about some key areas of prevention here and treatment in a second. But some interventions with this includes counseling and management, aspirin therapy, smoking cessation, and of course immunizations. But what I want to spend some time on here is to look at some of these recommendations related to nutrition and to pharmacotherapy and to exercise prescription, because these are factors that we're really focusing in on in order to improve their overall health as it relates to these particular conditions. Part of the reason why I want to highlight these next few behaviors is because they're vital for the treatment of diabetes, particularly with type 2 diabetes, because again, one of our goals is to try to reverse the disease. And with proper diet, physical activity, and weight loss changes or weight management changes, individuals could completely change the course of their disease throughout their lifetime. And if you remember earlier, we talked about these are the areas that have some of the greatest impact on the control of diabetes throughout. So other than individuals having good glucose control and monitoring daily, they also need to have good nutrition, good weight, and good physical activity levels. But the challenge with medical nutrition therapy, the challenge with dietary changes, physical activity, and weight loss is they're what we call complex lifestyle behavior changes, meaning it takes a lot of work and effort with patients in order for them to be able to be successful in this. This is not something that comes easy. It's one of the most difficult things to have individuals work with. If you remember everything we've talked about up until this point, we talked about how most of our environment is not conducive to healthy living, right? We are to be able to engage in the lifestyle behaviors of good nutrition, physical activity, and weight management. You have to be intentional about doing it. And the number one barrier for doing that is time. So it's really difficult for individuals to be successful with this, particularly on their own. And I'm going to talk about some programs you can refer them to that would help them to be successful in these areas. But they really need more than just a moment consultation or a 10 or 15-minute consultation with a physician. So I strongly encourage you to work with in your communities to have a network of providers for patients. In particular, finding individuals that do lifestyle behavior change programs. These are typically public health professionals or exercise physiologists. They have been trained in these areas, and they tend to be very, their ability to engage individuals in this can be really effective. We're going to talk about this in a second, but we also have the diabetes prevention program, and that is also given by trained individuals that have gone through the program and can teach that and can be really successful. So again, a one-time counseling is not going to be enough to get individuals to adhere. It's very difficult, and it takes a longer process in order for them to do that. And they really need help and to be able to do that. And this has been deemed eligible to be covered by insurance and highly recommended. And so many insurance companies will pay for these types of programs. So we can talk about considering that as well. So let's talk about the American Diabetes Association nutrition recommendations. It's really an individually developed dietary plan. So it's when an individual is diabetic, we really strongly recommend that they see a dietitian. They're going to look at metabolic nutrition and lifestyle requirements. I tend to recommend dietitians over nutritionists because dietitians are trained in clinical disease. They have a little bit more training than nutritionists, so I highly recommend that they see them. And they will tailor a plan that will fit their diagnosis, right? Consideration is really given to each micro or macronutrient, which would be our proteins, fats, and carbohydrates. And so what they're looking at here is protein intake, about 10 to 20% of daily caloric intake, so not too much different than what we talked about. There's no evidence that indicates a lower or higher is of any value, so it's a pretty standard protein intake. Fat intake, we want to keep less than 10% for saturated and less than 10% for polyunsaturated. So we really want them to be focused on more unsaturated, healthy fats, and really keeping it to a lower fat intake of about maybe 20%. Cholesterol needs to be lower. Typically, the recommendation for healthy individuals is 300 milligrams a day. We want them to be less than 200 milligrams because they're at higher risk for atherosclerotic lesions. And then, of course, remaining calories would come from carbohydrates and monounsaturated fats. And this would be based on glucose, lipid, and weight control. But I think it's really important to understand that we used to think that we had to really control sugars and they should be avoided and replaced with starches. However, there's been little evidence to actually support this. So now the priority is given to more the total number of carbohydrates consumed rather than the source, because all carbohydrates can increase blood glucose. And so we're really focused on all of that. And we also want them to focus on nutritional value, because again, it can be very easy for individuals to focus more on just foods that they're eating and not so much the real healthy foods. So we want fruits, vegetables, whole grains, a plant-based diet, and then watching our meats and dairies after that. And again, we're having them count total amount of carbohydrates, not just the types of the sugar content there, because it's, again, really overall carbohydrates. But they're still able to eat a good amount of that. It's just being able to choose the ones of good nutritional value is kind of key. For pharmaceuticals, type 1, they typically have to have a daily supplemental or replacement insulin to help promote it. For type 2, it's when it gets a little different. First, we start with oral hypoglycemic agents. One of the most commonly prescribed is metformin. It helps to lower blood glucose and aid in insulin production. Severe cases, they're going to have both an oral agent and insulin to help with that. None of these directly affect exercise capacity, glucose availability, and we'll pick up with this in just a